Hello, can you guys hear me? Hello.
Yes, sir.
Okay, so how's your preparation going on? Do your task. Have you guys finished your task? Hello.
Sir, I have not done the UOD question,
Okay, so
yesterday's task.
okay, so you guys are supposed to do that today. Okay, and today we'll be discussing a lot of concepts from you world as well. We'll be covering the different diseases. So today's class is going to be fun. Okay, so let me just share my screen first. Okay. So as you guys already know the anatomy, so I guess that the pathology is going to be quite easy. So we are going to have an active interaction as well. So please do participate, right? So the pathology which we are going to discuss today is amyotrophic lateral sclerosis, right? Or ALS. Do anyone have any idea what is ALS? Hello?
No, sir, I don't remember.
Okay, anyone else?
Can I say?
Yes, please.
What
Yes,
I
please. Yes, please. Yes, you guys can participate, please.
Yeah, this is the neurodegenerative diseases that affects
Okay.
the nerve cells in the brain and spinal cord.
Okay, that's perfect, right? So actually, there is like a mutation in an enzyme which is known as zinc copper superoxide, right? And as we have mutation of zinc copper superoxide, this mutates, it would lead to formation of free radicals. Simple as that, right? So first of all, what's the cause? Why do we have ALS? As Dr. Sakharov just told us, in this disease we are going to have degeneration of different neurons, right? We'll be discussing specifically which neurons, right? But what's the cause behind ALS? So the cause is free radical injury, right? So free radicals would generate and it would cause injury of different neurons, right?
Yes.
Okay. Why? Because we do not have an enzyme. There is mutation in formation of enzyme, which is zinc, copper, superoxide, dismutase, right? Okay. As we have free radicals, right? So what would happen? Main thing which you guys have to keep in mind, we are going to have degeneration of two types of neurons, right? So as you guys are already aware of the anatomy of your spinal cord, let me just draw, okay, the spinal cord. So you have your butterfly, you have your lateral, your dorsal column, your anterior column. So, for example, if the neurons in the anterior horn are getting degenerated, so what do you expect? Would there be an upper? Will there be an upper motor neuron lesion or lower motor? If we have degeneration of
lower motor
Lower motor
neuron.
neuron.
Lower motor
perfect, so we are
neuron.
going to have problems of lower motor neurons. As we already discussed, if we have degeneration of lower motor neurons, there are certain signs and symptoms which are highly associated with lower motor neuron damage, right? So can anyone just tell me some of them?
Flaccid paralysis.
Flaccid paralysis,
Hypotonia.
perfect. Okay. What
Fasciculation.
else? Fasciculation. Okay, perfect. Fasciculation. Can anyone just tell me that why do we have fasciculation in lower motor neuron lesion? Why don't we have it in upper motor neuron lesion? Do anyone have any explanation of that? What is fasciculation, by the way? Hello?
A little bit of shaking.
Okay. For example, okay, what is fasciculation? For example, if I'm just mechanically, let's suppose if I have a muscle, it have denervation, lower motor neuron. For example, if I just touch that muscle or I just tap the muscle, you'll be seeing frequent movement of that muscle. That is known as fasciculation. And why do we have fasciculation in lower motor neuron injury? The idea is really simple. As we know, on the muscles, we have nicotinic receptors. Acetylcholine is going to act. Lower motor neuron is going to like dump of acetylcholine. So for example, if we have lower motor neuron lesion, it means that now this neuron isn't able to dump acetylcholine on this muscle. So what this muscle would do as a compensation, it would increase its nicotinic receptors. It would increase the nicotinic receptors. Are you guys getting me? It would express lot of
Yes.
because it isn't getting acetylcholine. So as an adaptive mechanism, your muscle are going to increase the receptors. So now if we are just lightly touching the muscle or we are just tapping the muscle, what happens? We'll be having extreme depolarization there, which would lead to fasciculation. Even with a mechanical force, now you can induce depolarization. Is that clear? Due to increased number of receptor on the surface of that muscle. Is that clear? While in the upper motor neuron, we won't be having fasciculation because in the upper motor neuron region, we have a lot of acetylcholine. The lower motor neurons are fine. Is that clear? Hello?
Yeah.
Yes,
Yes.
sir.
Okay. You will also be having atrophy of muscle. Atrophy of muscle. The idea is really clear. Why do we have atrophy? Because you aren't providing any stimulus. You do not have lower motor neuron. You cannot stimulate your muscles. And in the body, it's a general mechanism. If you aren't stimulating a certain organ or a certain tissue with time, it would undergo atrophy because the body would think that, it's non-functional. You don't have any stimulus. So why should I carry such weight, right? So it would undergo atrophy. Is that clear? So in ALS, first of all, we are going to have, like degeneration of your anterior motor neuron, that is lower motor neuron signs and symptoms. An important point which you guys should just keep in mind, we're also going to have degeneration of upper motor neuron as well. So in ALS, in the question stem, whenever you see that we have an individual, we have both lesions of the upper motor neuron and lower motor neuron, right? We know that the upper motor neuron sits in the lateral. Do you guys remember lateral column, right? The corticospinal tracts. Remember?
Yes, sir.
Yes,
Okay,
sir.
so we can have lesion in the lateral tract as well as we can have lesion in the brain, in the cortex, right? We know that the corona radiata are going to come from the pre-motor cortex. They would just pass through internal capsule, right? Okay, so let me just ask you a question. For example, okay, first of all, internal capsule is what's the arterial supply of internal capsule? Which artery feeds your internal capsule?
Middle.
Middle meningeal artery.
Medial
MCA.
Middle
MCA.
meningeal or middle cerebral artery?
MCA.
MCA. Perfect. So
Middle
there are
cerebral
small
artery.
branches which are known as lenticulostriate branches, right? So as we discussed in the lateral sulcus, whenever the middle cerebral artery is just passing, it would just give a small branches which are known as lenticulostriate branches, right? So it would just supply your internal capsule. And as we are already aware of, internal capsule basically is compacted form of your corticospinal tract. As the corticospinal tract are passing through your brain stem, they would just compact in a form of internal capsule. So for example, if the internal capsule undergo degeneration, let's suppose, what would you expect? Would I expect hyperreflexia?
Upper motor neuron lesion.
Upper motor neuron lesion. Perfect. So in upper motor neuron lesion, you will be like expecting hyperreflexia, right?
Hyper. Yes.
Or
Hyperreflex.
rigidity. So there is a term used which is known as Clapp's knife rigidity. Do anyone know what is Clapp's knife rigidity? Hello?
During passive stress, there will be initially high resistance, and then later it will decrease.
Okay. Okay. So what is Clapp's knife rigidity? You might have seen the knife, if you guys remember, if you are just closing that. First of all, it would be rigid, but when you just started closing it off, it would directly close. For example, if you are opening the same knife, what happens? First of all, you just apply force, and once an adequate amount of force is applied, it would open by itself, right? So the rigidity is like same as that of Clapp's knife, right? So on the passive movement, for example, we will be having rigidity. Why? Hyperreflexia due to upper motor neuron lesion, right? Okay, what's the concept behind Clapp's knife rigidity? I want to emphasize on that, right? For example, if this is my arm, if a person is having upper motor neuron lesion, for example, in the internal capsule, what happens if you are just like passively closing his arm? What happens? It would be very hard initially, but once you just apply an adequate amount of force, it will close off directly. Same as that of Clapp's knife. Why? What's the reason behind that? Because due to rigidity, if you are just like applying a passive force, you apply a tremendous amount of force, and this force is going to activate your Golgi tendon organ. You guys already know that the passive force which you are applying, it would be like such to a great extent that Golgi tendon organ is going to be activated. And what's the idea of Golgi tendon organ? You guys are already aware of that. It would, like close all of the reflex pathway, and once like it would just dump off inhibitory neurotransmitter. Do you guys remember? And once the Golgi tendon organ is activated with the passive movement of hand and upper motor neuron lesion, it would close off directly. Is that clear? That's why we have flat snap rigidity. Is that clear? Because the force which you are applying is so tremendous that it would activate your Golgi tendon organ, which is going to inhibit the reflex, inhibit the pathway, and then you can close off hand simply. Is that clear?
Yes, sir.
Okay, perfect, right? So in amyotropic lateral sclerosis, we are going to have both degeneration of anterior motor horn, which will just give us lower motor neuron lesions. We are already, okay, what about Babinski sign? What is Babinski sign?
Positive in the upper motor neuron lesion and it's negative in the lower motor neuron lesion.
Okay, perfect. So Babinski sign, for example, it's like fanning out of your, for example, normally if you just do a Babinski sign, for example, if you stimulate the sole, what happens? All of the toes and fingers would, like flex, right? But Babinski sign is positive whenever you are just undergoing this, this activities. You are just, it would fans out, right? So that is basically positive in upper motor neuron lesions, right? So in amyotropic lateral sclerosis, if the upper motor neurons are involved, so the Babinski signs will be positive, right? While on the other hand, if we have lower motor neuron signs and symptoms initially, you won't expect Babinski sign, it would be negative. But as the upper motor neuron involves, you'll be having positive Babinski sign. Is that clear? Hello? Hello?
Yes, sir.
Okay. So
Yes,
we discussed a pathology, if you guys remember, syringomyelia, right? What happens in syringomyelia, we discussed that, for example, if this is our spinal cord, right? So what happens, you are going to have formation of a cystic dilatation of syrinx, which can involve your anterior commissure, right? And in the anterior commissure, we discussed, we have that pain and temperature fibers which decassate 1 or 2 segment above. Did you guys remember?
Yes, sir.
And with
Yes.
time, yes, with time, it can also involve the anterior motor horn, and it would just spread even like in the end phases. This dilatation can spread throughout your spinal cord and it can involve different tracts, right? So,
Yeah.
for example, if here's a question for you guys. For example, if I have an individual of syringomyelia, right, and if the syrinx expands to certain extent that it also involves the upper and lower motor neurons. So how would we differentiate it from ALS? Yes.
It's the pain and temperature involvement.
Perfect. Perfect. So in
And as well,
ALS, perfect. So in
You-
syringomyelia, initially this syrinx is going to involve the anterior commissure. And in the anterior commissure, we discussed we have fibers of pain and temperature. While in case of ALS, the pain and temperature or the anterior commissure isn't involved. So in this way, you can differentiate these two pathologies. Is that clear?
yes, sir.
Hello? Okay, perfect. So the next pathology which we are going to discuss is Friedreich ataxia, right? So you have a lot of MCQs on Friedreich ataxia as well. Okay, let me just write it down. Friedreich ataxia. What happens in this pathology? Do anyone know? What's the cause of this pathology? Why do we have this condition?
it's a mutation of the frataxin gene.
Okay, mutation of frataxin gene. Okay, for example, if let's suppose an individual is having mutation of frataxin gene, what would happen? Like we have trinucleotide repeat GAA, right? So as a result of that, the gene would become mutated, right? So what would happen as a result of that? Yes.
The patient will have
Scoliosis.
Okay, no, like I'm just discussing, like, for example, let's suppose if we have mutation, what would happen? Why do we have it? What's the cause? Like here in this ALS, we discuss if we have problems with this enzyme, then we are going to have degeneration. So what's the cause of Friedreich ataxia? If we have mutation, what would happen as a result
the
of that?
mitochondria. It affects the
Accumulation of
mitochondrial
iron.
protein.
Okay, perfect. So basically this gene is important for your iron regulation, right? So
Yes.
without this gene, what happens, we will be having iron free radicals, right? Again, this iron would, like form certain free radicals, and that free radicals would again cause injury or degeneration of different neurons, right? So can anyone just tell me which group of neurons are going to be involved in Friedreich ataxia? Like, for example, if this is your spinal cord, right? As we already know the anatomy, so we are going to, okay, I don't know what's happening.
Spinocerebellar,
So just give me a second.
It's
lateral
spinocerebellar and
spinothalamic, spinocerebellar, lateral
And dorsal.
spinothalamic tract, and spinocerebellar.
Dorsal column.
Okay, perfect. So, for example, if this is our spinal cord, so we have different tracts. That is spino, happens to, okay, spinocerebellar. So, for the spinocerebellar, we discussed we have two tracts. They are going to enter into cerebellum ipsilaterally. Did you guys remember the anterior and the posterior, which are present in the lateral column? Did you guys remember that?
Yes.
Okay, so these free radicals would just cause the injury of spinocerebellar neurons, right? The tracts. So what would happen as a result of that? The sense of position, the sense of proprioception, that is the subconscious, it won't be going into your cerebellum. So we will be having ataxia, right? Ataxia. Is that clear? Similarly, if the lateral column is involved, we also know that we have corticospinal tracts in the lateral column as well. So if the corticospinal tract due to these free radical injury are damaged, so what would you expect? Upper motor neuron lesions or lower motor neuron lesions?
Upper motor neuron lesion.
Perfect. So we'll be having upper motor neuron lesion. And what happens in upper motor neuron lesion? The Babinski sign would be positive. We are going to have hyperreflexia, if you guys know that, right? Okay. So these free radicals are going to damage mainly the tract of your lateral column, but it can also damage your dorsal column tract as well. So the DCML, if damaged, what would happen? Yes.
Loss of proprioception and
Perfect. Lack of
Vibration.
lack of proprioception, and we are going to have 2 points discrimination as well. That will also be compromised, the modern sensation. Remember?
yes.
Okay. So what else? There are other features which are also associated with Friedreich ataxia, right? So we are going to have a condition which is known as spes cavis. Do you guys know what is spes cavis?
Yeah, it's a foot abnormality.
Perfect. So we are going to have foot
High arch
abnormality.
foot.
High arch foot. Like, for example, if this is the foot, so what's happening to my pencil? I think it's mad again. So we are going to have high arch foot, right? So the foot would be like high arch. And what else? We are also going to have kyphoscoliosis. That is bending of your, simple. You can just remember bending of your vertebral column, right? Or the vertebra, right? So these things are associated with Friedreich ataxia. And very high yield thing which you guys should remember, that individuals with Friedreich ataxia would also be having hypertrophic cardiomyopathy. One of your UWorld MCQ, right? So these individuals would be at high risk of hypertrophic cardiomyopathy, right? And you already know hypertrophic, what happens in hypertrophic cardiomyopathy due to gene mutation. We are going to have functional stenosis. We have already covered that in our CVS module, if you guys remember, right?
Yes.
Okay. So let me just give you like an overview of Friedreich ataxia. What happens? We are going to have gene mutation, or that is, we are going to have trinucleotide GAA repeat. And as a result of that, what happens? We are going to have improper or inappropriate regulation of your iron, which would lead to free radicals, right? And these free radicals can cause degeneration of different neurons. They can also cause degeneration of your cerebellar neurons, right? Cerebellum directly, remember. It can also contribute to ataxia, right? Okay. So the upper motor neurons are going to be involved, spinocerebellar and dorsal column, right? And once they are involved, we are going to have different signs and symptoms. We already know the anatomy. For example, if the spinocerebellar are involved, we are going to have ataxia. If the upper motor neuron are involved, we are going to experience like upper motor neuron symptoms. If the dorsal column are involved, DCML is gone. This individual won't be having sensation like, for example, the modern sensation, 2 points discrimination, vibratory sense, and what else?
Proprioception.
Yes, proprioception. Perfect, right? So this was all about Friedreich ataxia, and you can also see the other symptoms which are associated, like high arch feet. And besides that, this individual is in the future he is prone to have hypertrophic cardiomyopathy. Is that clear?
Yes, sir.
Okay, perfect, right? So the next group of disorders which we are going to discuss today is like the demyelinating diseases, right? Demyelinating disease or okay. So we have two group of diseases which we are going to discuss in detail. That is multiple sclerosis and Guillain-Barré syndrome. Can you guys just differentiate what is the main differentiating features of multiple sclerosis and Guillain-Barré? Yes, you already discussed that in
In
previous class.
multiple sclerosis, it's a central nervous system, and in Guillain-Barré, it's the peripheral nervous system.
Perfect. So both of them are demyelinating disorder. What happens? We are going to have demyelination. The myelin sheath won't be present. And if we do not have that insulation or insulatory myelin sheath, what will happen to the nerve impulse or the conduction?
Slow down.
Yes, the conduction would just slow down, right? Okay, so in multiple sclerosis, as the doctor told us, it's going to target your central nervous system, right? And in the central nervous system for myelination, we have specific kind of cells that are oligodendrocytes. So simply can I say that it would be demyelination of oligodendrocyte, while the Guillain-Barré is basically for peripheral nervous system. Peripheral nervous system, that is Schwann cells. Can I say that simply? Schwann cells demyelination, right? Okay. So, for example, in multiple sclerosis, let's discuss multiple sclerosis in a little bit detail. You already know that both of them are autoimmune diseases. Is that right? Hello?
Yes.
Yes,
We're going to have an autoimmune destruction of your, okay, due to molecular mimicry. We'll be discussing that, right? So we already discussed that autoimmune diseases are common in male or female. What do you think?
Female.
Female.
Female, perfect. So we are going to see the multiple sclerosis and okay, what's happening to the pencil? I don't know. Okay, so it's going to be seen in female, right? What happens? It's basically due to molecular mimicry, right? So, for example, certain inciting event would just produce a lot of antibodies or like autoimmune cells, and it would cross-react with your oligodendrocyte or Schwann cells, and in turn, it would cause demyelination, right? So, what are the characteristic features of multiple sclerosis? We already discussed that the optic nerve is basically a tract. Remember, it's basically like lined by oligodendrocytes. So, if the multiple sclerosis involves oligodendrocytes, so can I say that you'll be having sign and symptoms of certain eye, right? Eye signs. You'll be having blurry vision because it can involve your cranial nerve too, right? Because that's basically myelinated by oligodendrocytes. Can I say that?
Yes, sir.
And
Yes,
it
sir.
would, for example, if the cranial nerve is involved, it would end in a condition which is known as optic neuritis. So what would be the signs and symptoms of optic neuritis? You are going to have a lot of keyword MCQ on that. What would be the presenting features so that you can diagnose a disease that it's optic neuritis? Yes.
Decreased vision,
Okay,
Painful,
perfect. So we are going to
painful
perfect.
vision loss.
Pain on eye
Painful
movement.
vision.
pain,
Perfect.
headache,
Painful.
decreased vision,
Perfect.
Intranuclear
So we are
optima.
going to
and field
have
defects, visual field defects.
perfect. So we are going to have blurred vision. Okay, just give me 1 second, please. I want to correct my pencil. Just give me 1 second. Hello? Okay. So we were discussing that we are going to have optic neuritis. So what will happen in optic neuritis? Basically, we are going to have blurred vision, and along with that, for example, with eye movement, this individual would experience pain with eye movement, right? So whenever you see an MCQ in U World in which we have like classic signs and symptoms of optic neuritis, think of multiple sclerosis, right? Another thing which we discussed, if you guys remember, internuclear ophthalmoplegia, right? We already discussed that, so I want you guys to tell me what is internuclear ophthalmoplegia.
Sir, basically it's injury to the medial longitudinal fasciculus.
Perfect, that's perfect.
So the eye is not able to move medially during the lateral gaze.
Perfect. So we discussed what like we have medial longitudinal fasciculus, and what is the main goal of medial longitudinal fasciculus? It would connect your cranial nerve 3 and cranial nerve 6. So the medial longitudinal fasciculus is also myelinated by oligodendrocyte. So in multiple sclerosis, if you do not have that connection, what happens? The eye would not move, like the lateral gaze would be, right? So for example, if you do not have this connection, and let's suppose if this person is looking towards the left, so this eye can move, but for example, the other eye cannot be adducted, right? Let's suppose I'm just looking towards the left, an individual having internuclear ophthalmoplegia, right? So the lateral rectus of this eye is going to be like fine, but the medial, but the cranial nerve 3 for the medial rectus, it won't be, communicating with one another, which is simply known as internuclear ophthalmoplegia due to multiple sclerosis. What's the reason for that? The reason is that medial longitudinal fasciculus is myelinated by oligodendrocytes. Is that clear?
Yes, sir.
Hello? Okay, perfect. So we can also have like myelination. The tracts are also myelinated by oligodendrocyte. We already know that, right? Hello?
Yes, sir.
Both the ascending and descending tract. So for example, if we have demyelination of both the ascending and descending tracts, so what would you expect in this individual? Yes.
So there will also be the pyramidal tract demyelination, so we will have spasticity.
Okay,
And we
so
can-
can I say that there would be hemiparesis, there would be sensory loss, there would be like loss of sensation and weakness. Yes, there would be weakness, right? And it can also like involve, your autonomic nervous system, because autonomic nervous system, those tracts which we discussed, the hypothalamus spinal tracts, right? They're also lined by oligodendrocyte. So whenever all of these tracts are affected, there would be like the signs and symptoms of hemiparesis, weakness, and besides that, if the autonomic nervous system is involved, so we'll be having problems with bowel, bladder, and sexual dysfunction. Is that clear? So 3 things which you should just keep in mind. It's only, like what things are lined by, or what things are myelinated by oligodendrocyte. So your upper motor neurons, your sensory fibers, along with that, the medial longitudinal fasciculus and cranial nerve 2. So we'll be having problems related to that, right? So is that clear?
Yes, sir.
Okay. So how would we diagnose an individual with multiple sclerosis? The idea is really simple, right? So you'll be seeing something which is basically known as, yes, plaques,
MRI
right?
is
Yes. So we'll just undergo an MRI, and lumbar puncture is also a diagnostic criteria. So we'll be seeing like MRI plaques, right? And what are those plaques? The idea is really simple, right? So for example, if this is our brain and normally you are expecting a white matter, we already know that all of these tracts appear as white, right? So if we have degeneration of white matter, and you know that the myelin basically give the white color to these tracts. We already know that, right? So if we have degeneration of these myelin sheath, so can I say that there would be certain plaques or missing areas or some brown areas within white matter, some plaques within white matter? Can I say that?
yes, sir.
As we are just demyelinating, we are just, like degenerating the myelin. So what would happen? We'll be seeing certain plaques within that white matter, right? And another thing is lumbar puncture. As we already discussed that it's an autoimmune disorder. That is, we are going to have certain antibodies which are causing the destruction, your lymphocytes. So in the lumbar puncture in CSF, okay, where do we do lumbar puncture? We already know that we are going to, draw a hypothetical line through your iliac crest. Between L4 and L5, we are going to drain out, like the CSF, and there we will be finding oligoclonal IgG bands, right? Oligoclonal IgG bands, right? So oligoclonal IgG bands are going to be seen there, and we are also going to see myelin basic protein, which is basically the degraded component or degrading portion of your myelin, which indicates degradation or degeneration of myelin. Is that clear? So there would be gray appearing plaques within white matter. And what do you think would be the treatment option if this is an autoimmune disease? You already know that. Yes.
Plasma
Steroids.
steroids.
Yes, high dose corticosteroid can help because if you just suppress the immunity, so it can somehow help this individual, right?
Plasmapheresis also.
Plasmapheresis, perfect. So we can also remove the entire, immunoglobulins or the autoimmune cells by plasmapheresis. That's perfect. Yes, we can do
And
that.
and also anti-cancer like drugs that suppress the immune system.
Yes, anti-cancer drugs, perfect. So, for example, if it kills the reactive lymphocytes by anti-cancer drug, that can also help. Perfect, right? So it was all about multiple sclerosis. So who is going to give me an overview of multiple sclerosis? Yes, Dr. Satrov, can you just please give us an overview of this pathology, multiple sclerosis?
Multiple sclerosis is this is the immune mediated diseases that's
Okay.
just cause the body immune cells to attack the like the protective covers. It's called like the myelin sheets,
Okay.
the around the nerves.
Okay, perfect. So it would just like it's a demyelinating disorder of your CNS or oligodendrocyte, right? So what would be the like classical presenting features of an individual having multiple sclerosis? Yes. If the eye is involved, what would we expect? What would be the presenting feature? Yes.
Yeah, it's a bladder or bowel problems.
Okay, perfect. Due to involvement of autonomic nerves.
Yeah.
And what about involvement of cranial nerve too? What would you expect?
It's a vision problem.
Okay, perfect. Vision problem, that is optic neuritis, right? And pain when eyes are moving, right? So with eyes movement, will this individual experience pain, right? Which is a classic feature of optic neuritis, right?
And also there's like the or just balance problem, like the walking problem. The
Okay,
patient gonna have
perfect. So we can have weakness and hemiparesis as well, right? Loss of
this
sensations.
dizziness
perfect.
also. But
Okay, what else? How would we diagnose multiple sclerosis?
there is like the first thing that we have to it's about the like the medical history, and then we're gonna
Okay.
just make the MRI and then SFA analysis.
Okay, perfect. Okay. So this was all about multiple sclerosis. Let's discuss Guillain-Barré, right? So what do you think? What is Guillain-Barré syndrome? Yes,
Sorry, what?
Guillain-Barré syndrome.
Oh, so 1 second.
Ascending paralysis
Okay,
due
perfect.
to demyelination
So
of
Guillain-Barré
veins.
syndrome is okay, perfect. So it's basically demyelination of your Schwann cells or peripheral
Yeah.
nervous system, right? So if
Yeah,
we
yeah,
are having demyelination of peripheral nervous system Schwann cells, okay, remember, for example, if an individual is having Guillain-Barré, so what are the the trigger events or the risk factors of having Guillain-Barré? That is very high yield. You are going to have a lot of MCQ, right? Basically, what would you expect?
Campylobacter jejuni.
Perfect. So we can have like
TB.
Campylobacter jejuni infection. We can also expect for the upper respiratory tract infections. We can expect for the HIV. So right after that, if someone is, having signs and symptoms of Guillain-Barré, that is ascending paralysis, as Dr. Ramesh told us. So Dr. Ramesh, can you just tell it what is ascending paralysis? Would it be bilateral or unilateral?
Bilateral.
Perfect. So we are going to have bilateral ascending paralysis, right? So, okay. So as we discussed, what would be the triggering event or what would be like the risk factors? Can anyone just give me a summary of that?
URTI, Campylobacter jejuni, and indigestion.
Okay,
Yeah.
perfect. So Campylobacter jejuni, you have you will MCQ on that. Campylobacter vector, jejuni, very high yield, you guys have to keep in mind. Some viral illness, for example, upper respiratory tract infection, certain trauma, right after trauma or surgery, one can get Guillain-Barré syndrome, right? So again, it is also an immune-mediated polyneuropathy, right? So what happens, these immune cells would just go, it would cause demyelination of your peripheral nervous system, and specifically your Schwann cell, right? So once they undergo demyelination, so we will experience weakness. The idea is really clear in the peripheral nervous system, but it would be symmetric and ascending paralysis, right? Ascending paralysis. That is, first of all, the lower extremities are going to be affected, and then it would just come up, and it would affect your upper extremity in late phases, right? So whenever you see certain kind of history that we have an individual who is having some GI infection, right, and right after that he cannot walk, he cannot undergo, like he cannot stand, right? So it would basically indicate towards Guillain-Barré syndrome. Is that clear?
Yes.
Yes, sir.
Okay.
Yes.
Anything else? You are okay. Anything else? Or do anyone need to want to add certain things in this pathology? So you're open. You can just add.
Sir, it's also associated with the cytomegalovirus infections in
Yeah. So
rapid asthma.
cytomegalo EBV, right?
CMV.
Yes, cytomegalo EBV is also, it's also associated with EBV, by the way, right? Cytomegalo as well, right? So we are going to have ascending symmetric paralysis. That's all about the Guillain-Barré, right? So let's discuss certain other diseases apart from that, which is basically, like very high yield. You guys might have already done a lot of MCQs on that. So the first pathology which we are going to discuss is neurofibromatosis 1. Do you know what is neurofibromatosis 1? NF1?
So it's a mutation of the NF1 gene on chromosome 17.
Perfect. So NF1 gene is basically a tumor suppressor gene, right? On which chromosome? On chromosome number 17, right? So if you do not have that tumor suppressor gene, the idea is really simple. You're going to have tumors like in a lot of places, right? If you do not have a tumor suppressor NF1 gene, right? So where would we expect the tumors? We would just have a cutaneous neurofibromas. You guys already have a word MCQ on that. That is less than 2 centimeters. You are going to have a fleshy masses on your skin, right? Which indicates cutaneous neurofibromas. Is that clear?
Yes, sir.
Okay, we are going to have a characteristic feature that is who is going to tell me cafe OLED spots.
Cafe spots.
Yeah.
Yes, what are cafe OLED spots? They are coffee colored spots on the skin, right? So for example, if you see the skin, so we'll be having a coffee colored like spot present on the skin with some fleshy masses. So a lot of fleshy masses you'll see, right? That is less than 2 centimeters, lot of fleshy masses, right? Okay, what else would we see? What about pheochromocytomas? Individual can also have pheochromocytoma, right? If the NF1 tumor suppressor gene goes, what's the concept? If we do not have this tumor suppressor gene, we are going to have a lot of tumors, right? A lot of benign tumors. Pheochromocytoma can also be one, right? So what happens in pheochromocytoma? We already discussed that. Yes. Who's going to tell me? Pheochromocytoma. Hello? We already discussed pheochromocytoma. What is pheochromocytoma?
Sir, it's a tumor of the adrenal glands.
Adrenal medulla or cortex?
Adrenal medulla.
Medulla.
It's our tumor
Perfect.
Excess active.
Adrenal. Perfect. So if we have tumor of adrenal medulla, what would happen? We are going to have, it's going to dump off a lot of epinephrine and norepinephrine. It's a kind of big sympathetic ganglion, right? So what would happen? What would happen to the metanephrine level in pheochromocytoma? We already discussed this in endocrine section, if you guys remember.
Yes, sir.
Metanephrines would be elevated, right?
Yes,
Okay.
sir.
So this individual can also have optic glioma, that is on the surface of the optic nerve. Like, for example, if this is your eye, he can have a big tumor on his optic nerve as well, which is known as optic glioma, right? Is that clear? So this was all about neurofibromatosis 1. So we have another variant of neurofibromatosis, that is neurofibromatosis 2, very high yield, right? So we have certain things which are associated with neurofibromatosis 2. Basically, it's okay. So let's discuss one of a UWorld MCQ. We have these cutaneous neurofibromas. These cutaneous neurofibromas are derivatives of which cells? What do you think?
Neural crest cells.
Neural
This
crest
Schwann,
cells.
Schwann cells,
Schwann
perfect. And
cells.
Schwann cells in turn comes from neural crest cells, right? So you have a UWorld MCQ on that. Okay, let's discuss neurofibromatosis 2. Again, neurofibromatosis 2 is also like the same tumor of Schwann cells, right? It's also known as like vestibular schwannoma, if you guys remember, right? Hello? So in
Yes, yes.
neurofibromatosis 2, what happens? Again, we have mutation of NF2 and F2. What is NF2? NF2 again is a tumor suppressor gene, right? Gene for Merlin, right? So if we do not have this gene, what would happen? It would end vestibular schwannoma. That is, the Schwann cells can develop a tumor, right? And what's specific about, okay, they are also known as acoustic neuromas, right? If you guys remember, because it would invade which nerve? Yes, which nerve is highly associated with neurofibromatosis 2?
Eighth
cranial
Eighth
nerve.
cranial. Perfect. So if the eighth cranial nerve is involved, what would you expect? What is the function of eighth cranial nerve?
Hearing loss
Hearing
Okay, perfect. We are going to have hearing loss. What about balance?
and balance. Yes.
Yeah.
Balance, perfect. An individual can also
vertigo, thing
experience
like that.
vertigo, perfect. Tinnitus, right? So these are all things which are associated. Okay, neurofibromatosis 2 or the vestibular schwannoma would tend to spread where in your brain stem? What's the specific area?
Posterior fossa. And the
Okay,
schwannomas will
fossa?
be at the CP angles, and the
CP angle.
ependymomas will be in the posterior fossa.
Perfect. So ependymoma would be basically in the posterior fossa, while the schwannomas would be present at the CP angle. That is, yes, what is CP angle? Cerebellopontine
Cerebellopontine
Pontine
angle.
right? Okay, perfect. So let's discuss our next pathology. These are like a group of small pathologies which are very high yield. So you guys should focus on that as well, right? Von Hippel-Lindau disease. What happens in VHL or von Hippel-Lindau disease? The idea is again same. VHL is a tumor suppressor gene present on chromosome number 3. If we have deletion of VHL, if we do not have VHL, we cannot suppress tumors. So we are going to expect tumors in different locations. Where would we expect the tumors? In 3 locations, right? That is hemangioblastomas, in the retina, in the cerebellum, right? Hemangioblastomas. What are hemangioblastoma? What do we mean by hemangioblastoma? Hello?
Tumor of capillary.
Perfect. The word hemangio basically means blood vessels, right? So we are going to have highly vascularity, that is tumor of your capillaries, where in your retina and cerebellum. What else? This individual can also have renal cell carcinoma, right? Renal cell carcinoma and pheochromocytoma. So you guys have to remember 3 things with von Hippel-Lindau disease. That is hemangioblastoma of cerebellum. If the cerebellum is involved, the idea is really simple. This individual will be having ataxia. Similarly, you can also have like renal cell carcinoma. Okay, so you guys are going to tell me renal cell carcinoma tends to release which hormones? Yes. Which
EPO.
hormones are?
Erythropoietin.
Erythropoietin.
What else?
Erythropoietin. It gives,
Aldosterone.
Aldosterone. Yes. What? Okay. So you have an NBME MCQ on renal cell carcinoma, right? So it would release EPO. And if the EPO is released, the idea is really simple. We are going to have, yes, which pathology is associated with increased EPO?
Polycythemia.
Polycythemia, perfect, right? So in NBME 30, you have the same MCQ. You are going to see that, right? So like, you know that it's very easy, but you guys have to remember, you guys have to connect these diseases with one another, right? So either they can ask the von Hippel-Lindau, aspect of this pathology, because it can also lead to renal cell carcinoma. They can also give you signs and symptoms of polycythemia, where you have to connect it with renal cell carcinoma if there is any history of, hematuria and things like that, weight loss. So you must associate all of these pathologies, right? Okay. So the last pathology which we are going to discuss is very interesting.
What's
Sorry?
the third pathology here? Hemangioblastoma, renal cell carcinoma, and what's the third one?
And pheochromocytoma again, right? Pheochromo. Okay, sorry, I don't know what happens to my pencil. So that's why I'm not able to write a lot of things. That is pheochromocytoma, right? So again, we know what is pheochromocytoma. It's basically tumor of your adenomedulla, increased metanephrine and things, right? So let's discuss our last pathology, that is Charcot-Marie-Tooth disease. Who is going to tell me what is? Yes, please.
Excuse me, sir. Yeah, you said renal cell carcinoma release EPO and which other hormone?
Sorry?
You said
EPO, erythropoietin, and
and which
aldosterone.
other? Okay, that's
Aldosterone,
good.
right?
Thank you.
Okay.
Thank you.
Okay. So let's discuss our next pathology, that is Charcot-Marie-Tooth disease. Okay, so you guys are going to tell me what is Charcot-Marie-Tooth disease? What happens in this disease?
So, sir, basically there is a defective production of myelin, mostly in child or adolescents, and it mostly
Okay.
is the lower extremity muscles, resulting in foot drop. So that's
Perfect. Okay, I want to hear one thing which is like very highly specific for Charcot-Marie-Tooth disease. Okay, is it a disease of older individuals or like those who are adolescent?
adolescent and children.
Okay, perfect. And it's a kind of, like inherited hereditary disease, right?
Yes, sir.
Okay, and it would involve distal muscles or proximal muscles? First,
Sir, I think distal muscles.
distal muscles, right? So three things which you guys should just keep in mind. For example, in the question stem, if you see an adolescent, for example, an individual of 15 to 20 years of age, right? And suddenly he developed weakness and he cannot walk, he cannot run, right? And in the history, you have like some same things related, like for example, if his father is having same condition, so you should think of Charcot-Marie-Tooth, right? That is basically, okay, what's the details, as the doctor already told us. It's a hereditary disease in which what happens, basically we are going to have defective production of proteins, and these proteins are basically involved in like formation of structure and functional peripheral nervous system myelin sheath, right? So again, it's a disorder of myelin sheath. If the myelin sheath isn't there, what would happen? It would lead to neuropathy, right? And what happens? We are going to have involvement of lower extremities first, right? Lower extremities, but the distal muscles are going to be involved first. Distal muscles are going to be involved first, right? So, and it's a disease of adolescent, right? Charcot-Marie-Tooth disease. So three things which you should just keep in mind. It can also lead to foot drop, right? If the lower extremities are involved, right?
Yes, sir.
Okay, which nerve impairment lead to foot drop? Yes. You already did that.
Common peroneal nerve.
The perennial
Okay,
nerve.
branch of common peroneal. Which branch of
Deep
common
peroneal.
peroneal?
The deep
Deep
perennial.
Perfect.
Deep peroneal.
Perfect. Deep branch. Okay. So this was all about Charcot-Marie-Tooth. Let's discuss. Let's have some a normal discussion, right? So officially the class is over, but let's discuss some of the new word concepts, right? Is that clear?
Yes, sir.
Yes, sir.
Okay. Just give me 2 minutes. Let me just give me 2 minutes. We'll be having a UL discussion, right? Just give me 1 minute.